Good morning. This is Ivan Pacheco again, presenting the part two of the melanoma variants, the Greek mimic, part of the series of basic lectures on melanoma. Dr. McKee is back here. Thanks to him again for his generosity and his time and dedication to us. So, Dr. McKee.
Okay, well, it's lovely to be back, and hello to everybody who has joined us, whether they're from McKee or otherwise, and it's lovely to have people from different countries, excuse me, from all over the world joining us. It makes us into quite a nice family. Now, I wanted to start with some acknowledgements because I wouldn't be able to give these talks if it wasn't for the kindness of so many different people around the world, personal friends and colleagues, and more recently, friends and members of McKee who regularly provide the most wonderful cases, which has enabled me to put together many of the cases in these lectures. And I thought it would be nice just to acknowledge them all. And you can see in that middle bullet point, there's a whole bunch of people, and I'm not going to mention them by name, but you can read them. And I also wanted to thank Ivan because this is all his brainchild. It's got nothing to do with me whatsoever. He contacted me initially and said, would I like to do some lectures for pathologists from various countries in South America? And I said, sure. And then somehow or other, it sort of morphed into something much bigger and involving McKee and Facebook. So I'm very grateful to Ivan for setting this up. He's a wonderful guy. Now, I just wanted to emphasize to you, with the exception of desmoplastic melanoma, and Spitzoid lesions, I suppose, the only importance of these variants of melanoma is that it would be very easy to not realize they were a melanoma in the first place, and you would think of them as being something else. And that would obviously result in a delay in appropriate treatment, and the patient could come to great harm, and so on and so forth. And so it's important to always have, when you're looking at a funny tumor that's not instantly saying what it is to you, it's always good to have melanoma in the back of your mind, because melanoma can just do anything it likes. And that's the important point, really. Now, I wasn't going to talk about bullous melanoma, really, but I couldn't resist it when Professor John Han Ho from the University of Pittsburgh, and he's the director of Kiko.com, which is a wonderful knowledge sharing platform. And he shared this case with us. And you can tell, wait a minute, this got excited. You can tell that this is either from the palm of the hand or the sole of the foot because of this great big thick stratum corneum. And clinically, this would have presented with sort of little tiny blistery lesions underneath the stratum corneum, giving rise to a dyshydrotic eczema-like appearance clinically due to the presence of these great big spaces, these little blisters, which are stuffed full of melanoma cells. So that's an intra-epidermal bullous variant of melanoma. And it's not of any consequence, it's just that it's very pretty. and I thought I had to share it with you because it was just lovely. And then yesterday, it was amazing. I was thinking about this talk, and yesterday we had another case, and I thought, gosh, I have to share this. Now, those of you who've been looking at McKee yesterday would have seen this case, but others who didn't, or members of different groups, won't have seen it. But this is an incredible case. Wait a minute, hang on. I've lost I should have moved that over. Unfortunately, the full name isn't present. But this was a man in his 40s who presented with a roughly 2 centimeter diameter blister on his toe. And clinically, it was a blister, and it was biopsied as a blister. And when you look at the low part, there's a nice subepidermal blister. And there's the dermal papillae projecting into the blister cavity. But if you look carefully at the base, you can see this tumor. And in fact, on the low part, if you go to the edge, you can see there's in situ melanoma in it. And on the top right, there's obviously melanoma. And this is HMB45. So that's a bullous melanoma that presented clinically with a blister. I just want to go back to my acknowledgements because now, there we are, Dr. Ebert Torres from Lima, Peru. I wanted to make sure he got credit for that case. So that's just a second example of bullous melanoma, but this was striking because normally what you see is you see a melanoma with a bit of a blister somewhere or other, and the blisters can be subcorneal, or they can be intraepidermal, or they can be subepidermal, and generally speaking, the blister is just an incidental finding, but this particular case, it was the primary clinical appearance, which is very strange. And then I found this case, which I should have shown you, but I didn't, so I thought I'd make up for it now. This is a desmoplastic melanoma that Eduardo shared with me. I have no idea what the patient's age is. Or where it was from. It's just an old archived case. But there you can see a pretty typical desmoplastic melanoma. And there's the surface where we're not really picking up an in situ component, which is not uncommon in this tumor, particularly when you get recurrences. But the reason I'm showing it to you is because of the enormous neurotropism, which really is quite staggering. And it's also particularly interesting because here the desmoplastic melanoma were spindle cells, but these look much more epithelioid. And I don't recollect having seen anything quite like this before or since. It's not really going, you see, that nerve has been completely replaced, and there's spindle cells on the outside, but then all around it, it's much more epithelioid. So I thought that was just, isn't that gorgeous? It's just so beautiful. There are the axons there, and there's the melanoma. I think you could look at this, and there's another view. And there's a high part, just to show the nerve. So and one more. Now, I put this case in as well, because this is another one I meant to share with you. This is another case where you can get caught out very easily. Now, unfortunately, we're not interactive, so I can't quiz you. But this is the sort of case that it shows we'll accept that it's a melanocytic lesion, and it extends from the dermoepidermal junction all the way down into the subcutaneous fat. So it looks a bit like a congenital nevus, and clinically, that's what they thought this might have been. And I wanted to draw your attention to how easy it would be to make a mistake, because there's the top part where we're looking at type A nevus cells, although they're a little bit pleomorphic. So those nuclei should catch your eye. They are pleomorphic. But when we look at the right-hand side, you can see there's nice maturation with depth, with even spindle cells. So this field here looks like type C nevus cells, but on the left, it's a bit worrying. And then there's a close-up view again. This is the top of the lesion. This is the bottom. And you can get the idea that, in fact, that maturation is not really true, because, yes, the cells are dispersed, but actually the nuclei, many of the nuclei, like there's one there, which is exactly the same as the nucleus at the top. So I think that's a sort of a false maturation. And then when I come back to the low power, I put an arrow to draw your attention to that little nodule there, which, when you see a nodule in a melanocytic lesion, there are two things you have to think about. One is melanoma, and the other, I suppose, would be a proliferation or a proliferative nodule. And I'm going to talk about them later. But there's this nodule here, which is very expansile. But I think it's pretty obvious from the cells around it one's dealing with a melanoma. And there's some wild nuclear pleomorphism. And the thing was full of mitoses, but there are a couple there. So that was a melanoma that at low power you might have thought was a congenital nevus. So be careful when you get such a lesion that you don't forget to look at it properly. The key, to diagnosing melanoma is looking at slides properly. It's very easy when you have a busy work day and you're in the sort of practice that I was in Boston, where one got scores and scores of nevi every single day, and the temptation to whiz through them had to be resisted, because you really can't afford to do that. And I think if someone's got a biopsy done, then it's up to you to look at it properly. Now, we're going to talk about a whole bunch of these variants of melanoma, and they're all very, very pretty, and they have different implications. And so the first one I wanted to touch on is balloon cell melanoma, or if you like, you can call it sebocyte-like melanoma. And this is the most important, but I highlighted it in red there, that balloon cell melanoma must be distinguished from a balloon cell nevus. And my experience is balloon cell nevus is much less common than balloon cell melanoma. Now, there is a sort of an odd classification, which I've never really understood, whereby if a lesion is greater than 50% balloon cells, you call it a balloon cell nevus or a balloon cell melanoma. And if it's less than 50%, you call it a nevus with balloon cells, or in the melanoma with balloon cells, which doesn't really make much sense to me. There either are balloon cells or there aren't, and it doesn't really matter which you call it. The important point to remember is balloon cells are not that uncommon in melanoma. You just have to look for them, and if you do, you'll find them. But pure balloon cell tumors, melanomas, are rare, but pure balloon cell nevus is even more rare. So when you see a balloon cell melanocytic lesion, you start with the concept that this is melanoma, and then work backwards to see whether that's true or not. Don't do it the other way around. Don't assume it's a nevus. Start with melanoma. And this is true. Balloon cell change is more commonly seen in metastatic melanoma. And the point about balloon cell melanoma is the pleomorphism is quite variable. If you look at this slide on the right, you see a lot of the balloon cells have got a fairly central, rather regular hyperchromatic nucleus, which wouldn't necessarily worry you. So you might think, oh, this could be a balloon cell nevus, and that's true. But then you wander around, there's a funny nucleus there, and there's a great big nucleus on the edge of the photograph, and there's another one there. And those nuclei are the clue that you're not looking at a nevus. And you'll always find mitotic figures in a balloon cell melanoma. But again, it's a matter of looking for them. So this is a nice one. There's the surface, there's the stratum corneum at the top. And it's a melanoma that's a mixed picture. It's partly epithelioid, but it's mostly balloon cell. And if you look at the bottom right, there's a mitosis right in the middle of the field. And there are some very hyperchromatic and ugly looking nuclei. So I would hope no one would have any problems with that. Now, this is, I've looked at this case so many times. It's the most beautiful balloon cell melanoma I've ever seen. And this is a case that Antonina really kindly shared with me. And I did make a video of it. It's on the YouTube channel. But it's such a cool case. And I don't know the exact clinical history, but I think it's from the back because there's a very thick dermis. So that's most likely from the back. And there's this great big polypoid lesion on top. And if we look at it, there is that's at the side of the polypoid lesion. And so you can pick up that it's a melanocytic lesion. There's lots and lots of pigment, and you can see there's pagetoid spread, and there's some nuclear pleomorphism. So I don't think one has any doubt that that's melanoma. But if we then go away, that was actually over here. You can see there's a bit of residual, or there's some in situ melanoma in the bottom right-hand field of that top one. And you can see there are two populations of cells. There are more obvious balloon cells on the left side, there. And then there are these much smaller cells with bubbly cytoplasm. And this thing was teeming with mitoses. There's the mitosis there, and there's another one there. But these are in more sort of germinative looking cells. There's another mitosis, there's another one. So this thing was coming down with mitotic figures. Now, balloon cell melanoma, it doesn't behave any differently from any other melanoma. Its behavior is entirely dependent upon the thickness of the tumor rather than anything else. And the major importance of balloon cell melanoma, as I've mentioned, is mistaking it for something else, and particularly for a nevus. And Antonina also shared this case with me. This is a lovely balloon cell nevus, and you can see a great dome-shaped lesion with balloon cells occupying a significant part of it. But when we look at it at high power, you can see lovely type B nevus cells almost forming viable Palladi bodies. There are type B nevus cells, the hyperchromatic nevus cells, and at the top you can see some of the residual balloon cells. But the presence of type B nevus cells and neurotization tells you this is not a melanoma. Now, clear cell, well, a lot of people lump clear cell melanoma and balloon cell melanoma together, and I don't think that's really appropriate, although there is some overlap. But balloon cell melanoma develops because of melanosome degeneration, whereas in clear cell melanoma, for some reason, the cytoplasm gets stuffed full of glycogen. And so rather than having bubbly cytoplasm, you have clear cytoplasm, as you see on the right. And I just put that in because obviously clear cell melanoma differential is clear cell sarcoma, and clear cell melanoma expresses CD117, clear cell sarcoma does not. So this is a case that a wonderful pathologist whom I got to know many years ago, Zsolt Argenyi, and I'm sure many of the people who are watching know Zsolt. He's a superb dermatopathologist and general pathologist. And this, on the top left, you can see a melanoma with an in situ component, but on the right hand side and in the bottom you can see it's composed of clear cells with central nuclei. There's a mitotic figure there, and there's a huge nucleus there, so that again it's a pretty obvious diagnosis provided you look at it carefully. And this is one that Wayne Grayson shared with me. This one, the diagnosis is fairly easy because there's lots of melanin pigment dotted around the place. But this, I suppose, does show you the overlap you can sometimes see between clear cell melanoma and balloon cell melanoma, because there is some finely granular material in the cytoplasm in some of those cells. And this is a case that Alex Lazar from MD Anderson Cancer Center in Houston, Texas, shared with me. And it's a difficult case. On that slide, on that image alone, you'd be hard pushed to go straight for melanoma because you've got a mixture of spindle cells, clear cells, and bubbly cells. And I suppose you could have all sorts of differentials. But higher power view did show some melanin pigment, which makes life much easier. And again, rather like Wayne's case, that there's a mixture of clear cells and somewhat more bubbly cells. And this is a case, and I'm so pleased to be able to show it to you, because this is a case that the late Danny Santa Cruz shared with me. And he, as you know, he died recently, and he was a lovely man. Danny wrote a wonderful testimonial for me to help me get my O1 visa when I was moving to the States, and he also was instrumental in getting me my Harvard appointment, and he and I became great friends, and he was a wonderful character. Those of you who know him or who knew him, he was a lot of fun and a lovely man and a very smart guy. So this is a tumor. Perhaps you might think there's a little bit of something going on in the junctional region there, but most of the tumor is dermal, and it's composed of clear cells. And there's another view there. It was rather polypoid lesion, and composed of a rather homogeneous population of clear cells with a degree of nuclear pleomorphism. And there's the high powers there. Now, the interesting thing is, I think this S100 is positive, but the strange thing is it's not staining the nuclei. I don't know what this means. And melanoma stains scattered cells. I don't know whether Danny did HMB45 or Melanoma or anything else, but I have no reason to believe that this is anything other than a clear cell melanoma. But I'd be interested if any of you want to comment on that, as on the immunohistochemistry, I suppose, because it's certainly interesting. Now, the clear cell melanoma is quite a difficult tumor, and there's an awful lot of differential diagnoses that are important, because it can be quite easy to mistake a clear cell melanoma, particularly for a PEComa. Clear cell sarcoma is an important differential. Metastatic clear cell carcinoma is an important differential. I'm not sure these are really, but I put a few examples in just to show them to you. And the first one is a metastatic clear cell carcinoma that was very kindly shared with me on McKee just a short while ago. And you can see this huge tumor nodule, and there you can see areas of hemorrhage and nests of clear cells. There's some more hemorrhage there, and obviously you can do all sorts of immunohistochemistry if you want to, and you probably will do. But the easiest way to make that diagnosis is to just use the telephone and ring up the clinician and say, gosh, we've got a clear cell carcinoma in the skin. Is there anything in the clinical history that will account for this? And as I understood it, the patient was known to have a clear cell carcinoma of the kidney. So that made life very easy. And then we've got this really odd tumor, the cutaneous perivascular epithelioid cell tumor, or PEComa, although we still don't know what perivascular epithelioid cells are, even if they exist. But the PEComa is part of a group of tumors, including the sugar tumor of the lung, angiomyolipoma, and so on. These tumors may be a part of maybe a manifestation of tuberous sclerosis, but cutaneous PEComa is not. That's not to say you couldn't have tuberous sclerosis and get skin lesions, but if you get a skin lesion arising in isolation, then it's got nothing to do with tuberous sclerosis. And this is a case that Eduardo Colongi from the Institute of Dermatology shared with me. It's a beautiful case. There are, I think there's one or two examples that were regarded as malignant, but I'm not sure whether they, I don't remember about the clinical history, whether they metastasized or not. And the important thing about PEComa is that these tumors express melanocytic and smooth muscle markers. And so you might think it's a melanoma, but then you do calponin and smooth muscle actin and desmin, and you see that it's in fact it's one of these tumors. And it's a very striking histology, because there's an arborizing network of blood vessels, which you can see even on this low power, which sort of supports the tumor cells. You may see the odd mitosis, and it doesn't really matter. And there's another view there. And it really is such a pretty tumor. You can see that's a sort of a close-up view showing you the vasculature. And then we have another view. Here you can see in this field that there are two mitotic figures, but this apparently didn't do any harm to the patient. So I think we just have to regard it as well, there were mitoses, and that's that. And then clear cell sarcoma, which is obviously not really my territory. I've tended to keep away from connective tissue tumors. It was quite fun. I think I've told this story before, but it's a really good story. Chris Fletcher, he began his career as a medical student at St. Thomas's Hospital when I was on the faculty, and then he became a resident in pathology, and he and I became close friends. We connected. I think we have similar personalities, and we both smoked an awful lot, so we would enjoy Camel cigarettes looking at tumors. And he did a fellowship with me while he was also doing his MD thesis. And so he did a lot of dermatopathology, and then because of his thesis, we ended up looking at a lot of soft tissue tumor pathology. And I remember so clearly one day he said to me, he said, you know, Philip, I think the best thing is if you keep to the skin and I'll look after the soft tissues, that might be the better plan. And I was so grateful to hear that, because I found soft tissue tumors so difficult. So he went one way and I went the other. Anyway, clear cell sarcoma, as you know, is a young person's disease, and it has a typical translocation, and the tumor cells will express these melanocytic markers. And we'll look at this is one of the sort of mythologies of clear cell sarcomas. They're very often not clear cell, so I'm not quite sure why they're necessarily called clear cell sarcoma, but that's neither here nor there. So this is Alex's case, and these giant cells, particularly the one on the bottom right, these wreath-like giant cells and the connective tissue septa are very useful pointers towards clear cell sarcoma, and obviously the clinical history, and if there was any doubt, you would look for the translocation. Now, I put some cases in just for fun because I have them. This is a basal cell carcinoma, and I don't think any of you would have any problems knowing it's a basal cell carcinoma, but this is clear cell change in it. And if you just had the bottom right-hand field there and you didn't have any of this, you might have a great problems deciding what it was. So that could be a differential if you got a punch biopsy. And this is an outstanding case that Wayne Grayson shared with me. And if you didn't have this immunohistochemistry at the bottom, I wonder how many of you would have thought of this being clear cell change in an angiosarcoma. I don't think many of you would. I don't think I would have, but there's the CD31, the factor VIII related antigen. And in other parts of the tumor, it was more obviously angiosarcoma. But I thought that was just an amazing case. I had to share it. And then this is clear cell hidradenocarcinoma. In the top left, you see it's pretty obvious. It's an epithelial tumor. But in this part here, you might wonder about you might have a bit more problems deciding what the tumor was. But in the bottom right, there's nice ductal differentiation with the cuticles, so it shouldn't really be a problem. What I don't understand, I have to ask you about this. Every image has got this funny yellow thing. Do you see that as well as I do?
Yeah, it's like there's a circling around that.
Yeah, and it's on every slide, and I didn't put it there. I don't know what that means. It's very strange.
It's perhaps it's the arrow that is drawing around it.
No, I don't know. It's just very strange. Anyway, this is just a high power of a clear cell or perhaps a signet ring cell squamous carcinoma, in which there's tremendous what do you call it? transepithelial elimination of elastic fibers. But again, if you had that field on its own, I suppose that could be a melanoma, couldn't it?
Mm-hmm.
No, you see, there it is there. I don't know where that's come from. Anyway, myxoid melanoma is another important entity, and I'm a bit wary of it because there are so many myxoid tumors that may present in the skin that can cause so much confusion. But my bottom line is, when you see a myxoid tumor in the skin, if you don't know what it is, if it isn't obviously something diagnostic, well, then think about myxoid melanoma and do some immunohistochemistry. It's a rare tumor, and again, you tend to see it more in metastases than you do in primary tumors. And the tumors are frequently amelanotic, which makes the diagnosis much more difficult. And the mucin is stromal, so it's Alcium blue positive. It's not epithelial, so diastase PAS is negative. And again, the importance is you misdiagnose it. Now, this is the first myxoid melanoma I ever saw, and it's a beautiful example because it's not very difficult to diagnose it as a melanoma. Oh, hang on, it's jumping. There's a great big, oh, sorry about this, but the program has got a mind of its own. There's a great big tumor in, I'm not sure there's any junction activity, whether these are just, but I can't even remember if this is a recurrent tumor or a metastasis. Oh no, I think there's a bit of junction activity there, so it probably is a primary tumor. I couldn't remember. But there's, on the top right, you can see that's typical myxoid melanoma, where you see this mucinous material with little thin strands of tumor cells. And there's a little bit of melanin pigment there and there, which makes it easy. But if you look at the bottom left, then there's no melanin. And that could be anything, I suppose. It looks like a malignant tumor, but I would hate to try to say what it was without immunohistochemistry. But then on the bottom right, you can see melanin pigment. And in this large sort of cystic-like lesion, you can see melanoma cells are peeling off. And some people use the term acantholytic melanoma for that, but I don't really like that because I tend to think of acantholysis as being something to do with prickle cells, not with melanoma cells, but that's a small point. And there's some close-up views. There's more solid melanoma there with lots of mitotic figures. So obviously a melanoma. And this is a case that Wayne Grayson from Johannesburg in South Africa shared with me. And it's quite a difficult case because I can't remember whether I posted any. No, I didn't. I don't have the immuno for this, so you'll have to take it. You'll have to take my word for it that this expressed S100 and HMB45. But the Alcium blue shows you how much mucin there really is, and there was an awful lot. And then there's this case here, which I think this was the same case that I used at the very start in the text. And this is very kindly shared with me by a South African pathologist, Dorothy Lewis, who works in Lancet Laboratories in Johannesburg. And you can see it's a very myxoid tumor, and you might think of all sorts of myxoid malignant tumors, but there's a beautiful S100 protein expression. So that's some of the differential diagnoses, and I decided I really did not want to get into that because it would take forever, and one could spend a whole afternoon talking about these tumors. So you'll have to, if any of these concern you, you can do some reading yourself, I think. Now, I wanted to include this little entity. It's a more recently described one, lentiginous melanoma. It was also described as atypical lentiginous nevus of the elderly. And basically what it is it's an in situ melanoma that arises usually on the back or on the upper limbs. The literature has it in the head and neck, but I've never seen them now. The ones that I've seen have all been on the trunk, but I had to put this in because that's what the literature said, because I did a bit of a search to see what was going on. And this really is, it's the equivalent of lentigo maligna, but it's arising on non-sun exposed skin, so you don't get elastosis. And the tumor cells are predominantly along the basal layer, but it doesn't show the architecture and the stromal changes of dysplastic nevus. And this is a case that Eduardo Colongi shared with me, and this came from the back of a patient. And that's a pretty much a typical example. There's some pagetoid spread there. There's another cell up there. So it's a subtle melanoma in situ. And then this is a lovely case that Professor Konstantinos Kantounis from Greece shared with me, and he shared this is the dermoscopy, and I had to ask him to put some labels in because I unfortunately I never really got into dermoscopy. It was just beginning when I was at Brigham, and it was sort of at a very early stage and nobody seemed to know what they were doing. And I'd get these most peculiar descriptions which didn't really mean anything to me. And so it passed me by. But now I realize, and I eat humble pie, because dermoscopy is really fantastic. It's such a useful technique. And I mentioned a while back that the combination of clinical appearances dermoscopy and confocal microscopy can get so much information. It's absolutely incredible. But anyway, I think at least I hope you can see that this is an in situ melanoma, but it's not showing any of the features of dysplastic nevus or elastosis. And just for comparison, you see there's lentigo maligna gone mad. This is fully fledged in situ melanoma with a lot of solar elastosis in the underlying dermis. So that contrasts quite nicely with lentiginous melanoma. Now, I put this case in. Neuroendocrine melanoma is, I don't know how rare it is really, because one doesn't necessarily look for neuroendocrine markers in melanoma. But I did, when I was looking through the literature, come with the information that synaptophysin can be expressed in up to 10% of melanomas. So perhaps neuroendocrine differentiation in melanoma is not as rare as one might think. And in addition to showing all of the melanoma markers, it may express synaptophysin, chromogranin, CD56, and so on. And this is a case that Dr. Banerjee from Christie Hospital, he shared this with me about 30 years ago. But it's a wonderful case, and you might be hard pushed to know what that was without any immunohistochemistry, because it looks malignant. there wasn't any obvious melanin in it, and it does have a bit of a neuroendocrine look to it. But here's the immunohistochemistry. There's the melanin A and HMB45 on the top, and at the bottom, chromogranin and synaptophysin. Now, I truthfully don't know, but I couldn't find much in the way of literature on this tumor. And I don't really know whether it's of great importance or not, other than from an academic point of view. But perhaps some of you will have encountered these tumors. And if you have, I'd love to hear from you in the discussion time, because remember, it's a two-way process, and I'm trying to help you, but you can sometimes help me, and I enjoy being helped. Now, then we've got this. These are wonderful tumors. These are melanoma with heterologous differentiation, or sometimes called sarcomatoid melanoma or metaplastic melanoma. And this is a case that Alex Lazar shared with me, showing osteoid production in a melanoma. And these are awfully rare. And you may see them in metastases, but you can get them in primary lesions, mostly on the, particularly, the big toe is the commonly affected site. Now, I have no idea why that should be. I don't know what it is about the big toe that induces metaplastic bone and cartilage, but it seems to for some reason. And I've seen them on the thumb. So in my experience, they're most commonly on the toe, the big toe, or on the thumb and the other digits. And they are bad tumors, but it's because they're very thick by the time they present. Patients don't realize that this lump under their toe is of any importance, so they don't present to the clinician in time. And so by the time they turn up, they're sort of a centimeter thick, which is disaster. And the melanoma can produce any connective tissue component it likes, most commonly osteoid and cartilage. But you can see smooth muscle and skeletal muscle. And this, I think this was a lung metastasis, this case that Alex shared with me. So it's not strictly speaking skin, but that's neither here nor there. But there you can see, you'd be very hard pushed to call that a melanoma if you didn't know it, because there's lots of osteoid, lots of calcification. But the next slide, I think, shows us the immuno. Oh, I forgot to label it. The top one, I think, is S100, and the bottom one is HMB45. So it was a true melanoma. And then this is one of my favorite tumors. This presented on the big toe, and it's a strange tumor because you might think it's an exostosis or something if you didn't look at it carefully enough, because it's great lumps of bone with marrow cavity and so on. But then you look at the osteoid and you can see there are malignant cells in the osteoid. So this is tumor osteoid, not reactive. But there was melanin pigment scattered throughout, so it was not difficult to realize it was melanoma. And then that's sort of the edge where spindle cells merge imperceptibly with the osteoid. And there's a lower power view and a couple more views showing the same thing. And then there's this case which Wayne Grayson shared with me, which is a wonderful case. And this is a spindle cell melanoma showing well, it's not ganglion neuroblastomas, it's just ganglion cell differentiation, which you can see these large cells with abundant eosinophilic cytoplasm. And these cells, you can see the ganglion cells on the left, and these express neurofilament protein and synaptophysin, but elsewhere it was a fairly regular melanoma, so it's a beauty. And then I wanted to touch on melanoma arising in a congenital nevus, and I wanted to make, I'm doing this deliberately for a variety of reasons. People are very reluctant to diagnose melanoma in children. And I think that's with very good reason, because they're extremely rare. In the first year of life, the incidence of melanoma is about, I think it's 0.1 per million of infants. So it's desperately rare. And there are 1 or 2 reports of transplacental spread of maternal melanoma, but I've never encountered that. I wonder if anybody in the group can talk about that. If they've ever seen one, it would be very fascinating. But one of the problems with diagnosing melanoma in children is that most often it's a misdiagnosis. Mostly they're Spitzoid lesions, which got called melanoma because people didn't recognize they were a Spitz nevus. So that was always a problem. And the other thing is, in congenital nevi, most nodules in congenital nevi are proliferative nodules, not melanoma. I don't know the exact figure because it's very hard to tell, but I think it would be the order of 10 to 20 or 30 proliferative nodules for any melanoma that would arise in a giant congenital nevus. Certainly giant congenital melanocytic nevus with melanoma is very rare. These are the figures you see in the literature. I'm not sure whether I believe that or not, you see, because the problem is the literature has gathered together all of the cases that have ever been described. And so you don't know how many of those were actually real melanomas or proliferative nodules, because you're not in a position to review the histology yourself. So I don't know whether this is true or not, but this is the figure that I got from the pediatric journals. And maybe that's true, I don't know. But I have got one, and this was a congenital nevus. Now, the clue to melanoma in a congenital nevus with a nodule, there are 2 clues. One is necrosis and the other is hemorrhage. If you see hemorrhage and necrosis in a congenital nevus, it's very worrying and should start making you think, gosh, is this a melanoma arising in a congenital nevus? Because you should not see necrosis and hemorrhage in a proliferative nodule. Leastways, that's my experience, and I can only give you my experience. So this is this tumor, and there's all the hemorrhage, and that's a high power view of the tumor cell population. And there's another view here showing lots of mitotic figures. I'm on mitosis all over the place. And I think this tumor metastasized as well. So but again, as I said, it's very, very rare. That's a high power showing the edge of the congenital nevus of the banal bit. So then, I think this is my last topic. I wanted to talk about proliferative nodules. And these are so difficult. I think these are one of the most challenging aspects of dermatopathology, because, people argue like mad, is it a dysplastic nevus? Is it in situ melanoma? It doesn't really matter if it's in situ, whether it's a dysplastic nevus or in situ melanoma. it's chopped out and that's the end of it. But these things, you see, if you get them out of context, you get into real trouble. And I got into a terrible mess with this very patient, courtesy of an old friend of mine, Dr. Neve Leonard. And I think she was in Newcastle at the time. But anyway, this was a baby, and it was born with these great big nodules, and there was one on the head too. And I'll get back to that in a moment. But just as a general talk, proliferative nodules represent clonal proliferations, but benign clonal proliferations arising in a background, most commonly of a congenital nevus, and usually in a giant one, but they can arise in non-giant congenital nevi, and you may also see them in acquired nevi, but they're very rare in that last circumstance. And the important thing is, if you have the courage of your convictions, these things regress. And I know for a fact that those things all vanished with time. I don't remember how long it took. It may have been several years, but they all resolved. I'll show you the next picture because I got this as a consultation, and oh my goodness, did I have problems with it, because there's the congenital nevus there, and what? Sorry, I've gone too. And then we've got this separate population, which seemed to be quite distinct. It didn't merge imperceptibly. It was quite different. And this was the first proliferative nodule I'd ever seen, you see. This is 35 years ago. So I was quite green and young, and I didn't know better. And I thought this was probably a melanoma. When you look at those cells, you see they're very ugly with great big nucleoli, multiple nucleoli, very pleomorphic. So I thought this was a melanoma. And then I saw that clinical picture, and I thought, well, gosh, that can't be a melanoma. And so we did a bit of searching in the literature, and as I say, this is a long time ago. We discovered proliferative nodules, and we thought, well, that's what this is. So it's not a melanoma. And sure enough, the patient did fine, and that was the end of that. So we all learned by it. And then that's another view. And there's another view. I don't feel too ashamed that I thought this was melanoma. You know, it'd be very hard not to. And this is another one. Now, proliferative nodules, they can look like anything. They can, anything melanocytic. So they can look epithelioid, like type A cells, or they can be small cells looking like type B cells, or they can look like blue nevus. They can look like deep penetrating nevus. They can look like cellular blue nevus. They can look like neurocystic hamartoma. They can do all sorts of things. And sometimes they merge imperceptibly with the adjacent congenital nevus, but in my experience, at least, they tend to be more circumscribed, and they're you see, there's nevus there, there's nevus there. I suppose this is merging. Those are type C spindle nevus cells, and they're merging imperceptibly with this population of cells. So I suppose that bit, but they're not worrying. I mean, the nuclei are all pretty much the same, and I don't think I would be very worried about that. But there it did have the odd mitosis, but the important thing is knowing the clinical situation and knowing that this comes from a large congenital nevus, and then that'll help you, because the odds of it being melanoma are the odds are stacked towards it being a nevus, being a proliferative nodule. And this is a typical type B nevus, type B congenital nodule, or some people would call these small cells, rather like they're type B nevus cells. And there's the top of the lesion, and you can see residual nevus. And then when we go further along, you can see there's nevus in the bottom left, there's a hair follicle, and there's the proliferative nodule on the right and at the top. And there's another view there. And there is nevus on the left, proliferative nodule on the right. They are distinctive populations, but I don't think that would get you too worried, or it shouldn't. And there's another series of views there. And there's a high power of the nevus. And here's one that's fun. This is a case that these two cases, this one and the next one, I forgot to write it on the slide on the PowerPoint. This is one that Eduardo Colongi shared with me from the Institute of Dermatology in London. I think I was working there at the time because Eduardo and I used to work together. We had a great time. And the nevus is on the left, and there's the proliferative nodule, and you can see it's forming bone. So it's got metaplastic osteoid. And there's wait a minute, there is nevus on the left, proliferative nodule on the right, and then there are higher power views of the proliferative nodule, and then there you are with the metaplastic osteoid. So that I would think you'd be very unlikely to see another one of those. And then this is another one Eduardo shared with me, and this one is looking fibrohistiocytic. It looks like it's some sort of a sclerotic dermatofibroma, or even a sclerosing collagenoma type thing with a bit of a storiform pattern in it. And there's the nevus on the right, and there's a close-up view showing the connective tissue, the metaplastic component. And there is the nevus, the congenital nevus on the edge with a high power view there. And the last slide is just to show you how beautiful Cornwall is. That I took that photograph when we had a vacation down in Cornwall. If any of you haven't been there and you get the opportunity, it's a great place to go for a holiday. So thank you very much. That's not bad. I've done it in just a couple of minutes, over an hour. So I'm very happy to take questions or to listen to comments. So Ivan, shall we close up?
Yep, I think that's pretty good.
Let me just get rid of my power.
Now, I want to remind the audience that the copy, the version of this, recorded version of this lecture is going to be left on McKee Derm in Facebook, and I'm going to give a copy to Dr. McKee from my desktop or my computer. So then you can access it in YouTube, in the YouTube channel, Dr. McKee as well. Now, I have a couple of questions here that have been written by some of the audience in Zoom. I didn't get questions from Facebook. I'll say, what is the mitotic rate that you will be expecting to be present in a proliferative nodule? What is the rate of mitosis accepted in a proliferative nodule? Dr. Wafak.
I don't have an answer to that.
But you suggested some features of malignancy, which and
Yes, I
yeah.
think mitoses don't really necessarily swing you either way. You see, you've got to think about the context. So you've got this congenital nevus, and then for some reason it develops a clone of a cloned a separate clonal population of cells which start dividing and multiplying to give you a nodule. And you saw those nodules in that baby, and they were 3 or 4 centimeters wide. So you would expect to see conspicuous mitotic activity because it's growing. The important thing is you don't see the pleomorphism and the mitotic act, not the mitotic act, the necrosis and hemorrhage that you'd expect to see in a melanoma. So I can't get, I can't, I've never dealt in absolutes. I remember Wallace Clark, he said you can have up to 3 mitotic figures in one H&E section of a melanocytic lesion. But if the nevus comes from a pregnant lady, you could have half a dozen, and it wouldn't make it a melanoma. So I don't really deal in absolute, so I can't answer that. Obviously, if they were all over the place, you know, if you were seeing 3 or 4 per high power field, then you'd be very worried about it, you know, as you would with any other tumor. But if you are picking up a mitosis one here, and then you look around, and there's another one, and you look around, there's another one, I don't think that would necessarily matter too much.
Now there is another question here, which is basically a general question regarding to the use of HMB45. How much should we rely on the graded pattern of HMB45 when on morphology it's not entirely supportive of maturation pattern? So I guess is how much would you rely on immunos? That's I think that's the question.
I don't really rely on immunohistochemistry at all. I'm an H&E morphologist. Immunohistochemistry is very nice, and if it works to support what I want it to do, then it's great, and if it doesn't, I ignore it. I think people are way too dependent. You see, here's an example. HMB45, you expect it not to be present in the deep part of a nevus, and it's present in a melanoma. But then you have a blue nevus or a deep penetrating nevus, and it's all over the place. P16 expression, you expect to see it lost in melanoma and not lost in a nevus, but it doesn't always work. And P67 can lead you up the garden path, particularly if you're not careful, because lymphocytes express P67. So I think I'm very old-fashioned, and it's not that I don't see a place for immunohistochemistry. It can be useful. I think it can be very useful for identifying in situ components in subungual melanocytic proliferations and early acral in situ melanoma. I think PRAME is very useful too. I think SOX10 is useful. I think we're going to a much better place now that we're using FISH and other molecular studies. I think I would put my faith in them, and I do hope that, you know, in the next 10 years or so, everybody will have access to that sort of investigative tool and not be so dependent on immunohistochemistry,
Let's see.
because it
Now,
can be very misleading.
now I think one of your new administrators in the Facebook group, Alice Roberts, is asking. Actually, she's saying, "Great lecture, thanks. I think everybody agree with that. And then, are atypical mitosis a concern in a proliferative nodule?
Gosh, well, they would be. Well, it depends how atypical it is and how many they are. I'm trying to think of this in context. If you found one atypical mitosis, would that make it a melanoma? I don't think so. I remember I used to diagnose Spitzoid melanoma on the basis of one tripolar mitosis in the superficial component, and then I was wisely educated that I was talking nonsense. So I'm not sure necessarily. You see, it again, it's context, isn't it? If you find one abnormal mitotic figure and that's it, and there's nothing else to worry you, I don't think you necessarily would say, "Oh gosh, this is a melanoma." No, I don't.
Now, I ask it.
I think it's always, you must look at things from the big picture. You've got to take a step back and look at the patient if you can, or read the clinical information so you know what you're dealing with in the first instance, and then look at the low power. Bernie Ackerman was a great man for low power diagnoses for melanocytic lesions, and some people disagreed with him, but I tend to agree with him. I think mostly when you look down the microscope, the first sight tells you, gosh, this is melanoma, or no, it isn't. And then you look at higher power and it confirms your diagnosis. I don't think it's very often that one actually is surprised by the high power view. And I think proliferative nodules are recognizable at low power, as they all, at least my experience, they all look like the ones I've shown you, or variations on that theme, and they're pretty recognizable. And so probably the best thing is not to spend too long gazing and looking and start counting mitoses. You don't need to lead yourself down the garden path and into trouble.
Now, you spoke about 50% for balloon cell nevus to be able to be called balloon cell nevus. Is it the same proportion present, or you should consider the same proportion for clear cell nevus as well, or melanoma? I'm sorry.
No, I only made that point to ridicule it.
Oh,
I think it's ridiculous that one should have figures like that. I mean, how do you assess something is 50% and not 49% or 48%? It's silly. And it doesn't really matter.
I think that comes from the literature of breast, that they say ductal carcinoma is more than 50%, and then special types are 90%. I think that some people want to have some guidelines.
Well, how would you assess it? You'd spend all day with a. How would you assess how much was balloon cell, and why would you bother?
Okay. I remember there was a case on Facebook that I thought, okay, this is a clear cell squamous cell carcinoma, and there were so many people saying those are features, this is a variant, and then what did you say at the end? With clear cell features? I guess is in the eye of the beholder in that case.
Sorry,
There was a case in your group with clear cells variant or features of squamous cell carcinoma.
Yes.
So in that point, I don't think that there is guidelines there of how much of what you have to have. And
no, I think it's just something you notice in passing. It's only when the whole thing is clear cell that, or if the whole tumor is balloon cell or clear cell, or signet ring cell, that's when you get into trouble. Because then if you don't have any melanin pigment, you have to think of melanoma in the first place.
So that was the learning point that you mentioned, right? Like if you have a balloon cell nevus, the first thing that you want to think and rule out is melanoma. I think that's the bottom line.
I think so.
Okay. So there is Dr. Karina Sidham.
Hello, Karima. How are you?
Joining us again, and she's saying hi. Marcella also is here, and she
Oh,
said,
hello, Marcel. I'm glad you've
and
joined us.
now if you wish, all of you people that are meeting here in Zoom, that you can activate your cameras, and
Yes, I think they should put their cameras on, then I
and you
can see
can
it.
ask directly too. And if anybody has any additional questions,
I recognize. And there's Antonina. Hello. And there's Marcella. Hi there.
yeah.
So,
So do you
who
have any
else?
questions? I mean, the floor is open basically, or comments. There is one more question here.
Sorry.
There is
Yes.
one more question here. Do metastatic melanoma have a tendency to lose melanocytic antigens, and how much SOX10 can help when all the melanoma markers are negative?
I've no idea. I've
Mm-hmm.
never encountered such a problem, so I can't answer.
Yeah. Okay.
You know, again, you see, it's looking in a way, it's looking at things the wrong way around, isn't it? If
Mm-hmm.
you've got a metastatic tumor and you look at it and you think it might be a metastatic melanoma, then the easiest way to get a diagnosis is to phone up the clinician and they'll tell you, patient had a melanoma excised there last year. And then you look at the tumor and you say, okay, it's a melanoma.
Mm-hmm.
Otherwise, you see, you end up with trying to make a thing into a primary dermal melanoma, and I'm always uncomfortable with that. Although we did have one, I think we ended up calling it a dermal melanoma yesterday on McKee Dam, but I was quite uncomfortable with that case. It was very difficult, but we ended up having to call it melanoma, you know? And it was dermal. There was no junctional component. There was no history of a primary tumor. So we'll have to see.
Antonio, do you have any comments on you, Marcella?
I imagine they're fed up listening to all this stuff. They've heard it so often. I can't teach them anything new. Don't forget, Marcella was my fellow for a very long time, and Antonina and I have been together now since. When was the meeting? It was 2017, wasn't it?
Yeah, I suppose it is.
So it's 3 years. So I can't teach them anything. They teach me now. You know, that it's role reversal. They know more than I do. So anyway, I think we probably ground the subject to death. There's only so much you can say about it, really. Now I've got a few more entities that I haven't touched on. We've got pigment synthesizing melanocytoma, and Artur Zembovich has very kindly agreed. He's going to do a 10-minute video, which we're going to include in the talk. And that way I don't have to talk about it, which is very, very nice because I don't really want to. And there are some other melanocytic entities, and there are some benign tumors, benign lesions that I forgot about, recurrent nevus and so on. I'll have to check what we did in the first two talks, but the last lecture in this melanocytic collection will be a bit of a potpourri of different things, but it'll just make sure that we've covered everything that we should have done. And if there's anything particular that you want that I haven't thought of, you can always send me a message and say, can we talk about such and such? Because it's good if it's interactive, you know.
We'll keep that in mind.
So, okay.